22-year-old primigravida with 13 weeks 5 days gestational age referred to as in view of low platelet count. She had history of childhood jaundice at 2 to 3 times at age of 6 years, history of jaundice and ascites in 2012. Patient was evaluated at AIG Hyderabad as decompensated cirrhosis. Her past medical record includes liver biopsy was done in 2012. It showed evolving cirrhosis with cholestasis. Autoimmune markers were sent. LChem was positive at AIG Hyderabad. Later repeated in Kamakoti Hospital, Chennai were found to be negative. She was in close follow-up with medical gastroenterologist and she was started on azathioprine 50 mg per day since 2012. No history of ascites, jaundice, edema since 2012. Upper GI endoscopy was done in 2022, which was normal. The patient was uncertain about whether to continue the pregnancy, so we provided counseling encouraging her to continue with the pregnancy. She had her regular antenatal checkups with us, was in close follow-up with medical gastroenterologist in view of low platelet count and cirrhosis. Ultrasound abdomen was done in third trimester. It showed splenomegaly with features of portal hypertension and few splenorenal collaterals were seen. Patient and her attendants were counseled regarding risk with normal vaginal delivery, including varicose rupture and massive hemorrhage. A decision was made to plan an elective lower segment cesarean section under spinal anesthesia. A multidisciplinary team meeting was conducted and patient and her attendants were counseled regarding risk associated with the lower segment cesarean section, includes risk of intrapartum and postpartum hemorrhage, need of blood and blood products transfusion, risk of venous thromboembolism, risk of varicose rupture, splenic portal collaterals bleeding, risk of shock, disseminated intravascular coagulation, acute kidney injury, liver failure, and need of MICU admission, and grave morbidity was explained. Elective lower segment cesarean section was performed safely under spinal anesthesia. Postoperatively, she was monitored in ICU for 12 hours and later we shifted her to room. Key learning points are pregnancy with cirrhosis and thrombocytopenia is a high risk condition. It requires multidisciplinary management. Early planning for delivery reduces morbidity. MICU preparedness is essential. Patient and family counseling is very important. Next, our medical gastroenterologist, Dr. Chaitanya, will continue the discussion.
Good afternoon, everyone. I am very happy to participate in this academic feast. So today I am discussing about pregnancy and CLD, what we have to be monitoring in CLD patients. So nowadays there is 7-fold increase in cirrhosis among women of childbearing age in the recent times. So there is current incidence of 2.5 patients in 1,000 women of childbearing age, they are having cirrhosis. Most of the cases are now due to NAFLD or MASLD. Previously it was due to viral hepatitis. Nowadays the prevalence is increasing for NAFLD. So pregnancy is possible in cirrhotic patients, but it is high risk and it required multidisciplinary care. So coming to pathophysiology, why pregnancy complicates CLD. So usually there is increase in plasma volume about 45% in the pregnancy. So it will increase the portal pressure and it will increase the risk of variceal bleeding. There are hormonal changes like estrogen and progesterone which may worsen the portal hypertension, and there is some altered drug metabolism which can cause various medication to not act properly, and there is hyperdynamic circulation. There is increased cardiac output and decreased systemic vascular resistance which will promote further worsening of the CLD, and there is compression of inferior vena cava in pregnancy which will increase the risk of ascites. So how will we risk stratify cases of CLD? So we have to check the MELD score. If MELD score is very low, less than 6, it is low risk pregnancy. There will be minimal complications. So standard monitoring is advised. Whenever the MELD score is 7 to 9, it is moderate risk. There we have to do monitor for some complications, and there should be some enhanced surveillance. If the MELD score is more than 10, it is very high risk for pregnancy and it is high sensitive with 83% of sensitivity. So we have to consider termination of pregnancy whenever the MELD score is more than 10. Coming to the complications, what complications we should expect in pregnancy. So there are liver-related complications and there are obstetric complications. For a patient with CLD, there is high chance that they will worsen during the pregnancy. Most common complication will be variceal hemorrhage. It will be noted in 30% of the patients. It is the most common finding. Followed by ascites. It can develop newly or it may worsen during the pregnancy. And many patients can develop hepatic encephalopathy, hepatorenal syndrome, and SBP during pregnancy. So all these things may worsen during the pregnancy time. Coming to obstetric complications, what we should expect? We should expect preterm labor. It will be seen in 30 to 50% of the patients, and there is high risk of postpartum hemorrhage. So it will be seen around 20% of the patient. Incidence of cesarean sections, ICU admissions, and blood transfusions will be higher, and there is high chance of maternal mortality with more in the decompensated liver disease patient. Coming to fetal and neonatal outcomes, we should expect preterm deliveries in around 30 to 60% of the patients compared to 4% in the controls. And there is high risk of low birth weights and intrauterine growth rate restrictions and intrauterine deaths and neonatal asphyxia. Coming to neonatal complications, patients can have NICU admissions, neonates, and there will be risk of respiratory distress syndrome and low Apgar scores and stillbirth rates up to 6%. So these things we should be kept in mind. So next I am going to discuss about the specific conditions, how to treat during the pregnancy. Coming to the viral hepatitis, it is common in India. So we have to check for hepatitis B. There should be universal screening recommendation for all pregnancies. So triple panel testing is advised. Not only HbS-Ag, we have to check for anti-HbS and total anti-HbC. So once we check these levels, if the patient is positive for hepatitis B and they have no viral load and not on any treatment prior, and we have to recheck the viral load at 7th month of pregnancy, that is 28 weeks. If the viral load is more than 2 lakhs, then we have to start treatment with tenofovir, which is safer during the pregnancy. Coming to neonates, after delivery, the baby should be given hepatitis B immunoglobulin within 12 hours of delivery. So the usual dose is around 26 international units per kg. So average we will give 100 international units of IV hepatitis B immunoglobulin within 12 hours of delivery. Coming to hepatitis C, there is no antiviral therapy approved during the pregnancy. So we have to avoid internal fetal monitoring and prolonged membrane rupture in these patients. We have to screen infants if more than 18 months for anti-HCV or HCV RNA after 1 month. So whenever hepatitis C positive pregnancy we have diagnosed during pregnancy, so we have to check the infant after 18 months for anti-HCV or HCV RNA after 1 month. There is no prophylactic screening test for the babies before that. So coming to autoimmune liver disease, how will we manage? So autoimmune hepatitis, we have to continue the treatment what the patient is getting already. Usually prednisolone and azathioprine are safer during the pregnancy. There is high risk of flares during pregnancy, around 20%, and there will be risk postpartum also, it is around 20 to 50%. So if patient is having well controlled disease for more than 1 year, preconception, then the patient have better outcomes. If the patient is not under well controlled disease, then we will advise them to postpone the pregnancy. And we have to avoid mycophenolate during pregnancy because it has some teratogenic effects. Coming to Wilson's disease, it is not that much common, but we should continue copper chelation therapy during pregnancy. Usually dipenicillamine and zinc are safer during pregnancy. There is 26% risk of spontaneous abortion overall. And if the patient was under proper management, the fetal losses are very fewer. So there are 3% birth defect rate, which was acceptable versus when we don't treat the patient with medication. Coming to portal hypertension and variceal management. So every pregnant patient before pregnancy should be screened for varices in CLD patients. Endoscopy in second trimester or preconception is advisable. We have to do variceal prophylaxis either by endoscopic therapy or beta blockers. In high risk patients, we can combine both therapies, both endoscopic variceal ligation along with beta blocker. Coming to during pregnancy, if the patient having any sudden hemorrhage due to varices, we should avoid using vasoactive drugs like terlipressin and octreotide. We should do endoscopic therapy, preferably endoscopic variceal ligation. And after the endoscopic therapy, we can start the patient on beta blockers to prevent further bleeds. So in some rare cases, due to portal hypertension, there is chance of splenic artery aneurysm, which can cause rupture during pregnancy and is a rare complication. Coming to delivery, how will we deliver the patient? So usually in CLD patients, vaginal delivery is preferred unless there are obstetric indications. But you should avoid, to prevent variceal bleeding, we should reduce the time duration in the second phase of delivery. We should avoid prolonged vasovagal maneuvers, and we have to monitor the patient post procedure. So in this case, what madam presented, the patient doesn't have endoscopy done, it was done 2 years earlier, and the ultrasound was showing signs of portal hypertension. So we don't want to take any risk for the variceal bleed, so we advised her to go for cesarean section. Hence her platelet counts are good and her INR levels are good, then we have no complications post surgery. So how to manage the patient? So it is multidisciplinary. We have to risk stratify before the pregnancy based on the MELD score and child score. There should be disease optimization, stable for at least 1 year before the pregnancy, and we have to give contraception counseling until patient is fit for the pregnancy. So medication review should be done, and some medications we should avoid, like mycophenolate or spironolactone for ascites. These medications we should stop before pregnancy. And we have to screen for varices. This is very important, either before pregnancy. If it is missed, then we have to do in the second trimester of pregnancy. So what we will do is, we will monitor the patients with CLD. We should check regular LFTs, and we will survey, growth surveillance of the fetus should be done. And we have to check for any blood pressure rise or proteinuria during the pregnancy period. So we should plan the delivery at a tertiary care center where multidisciplinary team is available, like hepatologist or gastroenterologist, and high-risk obstetrician, anesthesiologist, and neonatologist. So only with the multidisciplinary care we can assess the patient properly, and we can deliver the patient, and the child and mother's health will be in good hands. Thank you.